Good morning, everybody, and welcome. Our presenter today is Dr. Cornel Engelbrecht. He qualified in 1999 at the University of the Free State. He did his internship at Paarl Hospital and then did his community service at Bordonia Hospital in Uppington. He then worked overseas as a ship physician for some time and in a GP practice for 2.5 years in Stellenbosch. He then qualified as a specialist physician in 2017 at Stellenbosch University, and he started working at Mediclinic Midstream in 2018 in his private practice, where he has been ever since. He has a special interest in metabolic conditions and preventative medicine.
Not forgetting, he's a founder of the Wednesday and Thursday program. Thank you.
Thank you very much, Leanne and Emmanuel. So today I'm talking about hypercalcemia. I decided to just take one topic and instead of just talk, to try and condense it and keep it short, get some info on it. So, hypercalcemia is a relatively common clinical problem that we see. And the two most common causes, about 90% of cases, is primary hyperparathyroidism and malignancies. And we will look at the specific diagnostic approach to distinguishing between these two causes. So as we know, calcium levels are controlled by four things: PTH, or parathyroid hormone, vitamin D, and also in a lesser degree to calcitonin. And it all plays a role in the gastrointestinal tract, the bones, and the kidneys. So, the daily consumption of calcium is about 800 to 1,000 milligrams of calcium, and you get it primarily from dairy. 40% is ionized, and that's the physiological active part. The rest is bound to complex proteins, usually albumin. So it's quite important, as calcium and vitamin D deficiencies can contribute to bone fragility, and Dr. Cordino did give a nice presentation about osteoporosis. So if you want critical measurements of calcium, it's two important factors to remember is it has to be in the fasting state, and it also don't use a tunica. So if we look at calcium exchange, you can see 1,000 milligrams of calcium intake per day. About 350 gets absorbed, 250 gets excreted, and your extracellular fluid where your calcium is influenced by three factors: the kidneys, the bones, and then also the cells. So let's go back to a bit of physiology, and we all remember this picture. So the first important factor that we said plays an important role is vitamin D. And you get vitamin D through two sources: your diet and also your skin. It gets and the UV rays converts it to vitamin D hydroxylase in the liver. And it's the active part in the kidneys that is quite important with the absorption of calcium. The second important hormone, as we said, is your parathyroid hormone. And we will get to the parathyroid hormone a bit. So, as we know, there's 4 parathyroid glands. Your parathyroid hormone raises the ionized calcium as the calcium levels falls, and it basically has 4 mechanisms. It increases your osteoclast reabsorption in the bone, which is a rapid and fast process. It also increases your intestinal absorption of calcium, which is a slow process. Then it increases the synthesis of 1,25-hydroxy vitamin D3, which is a rate-limiting step. It also increases the renal tubular reabsorption of calcium, and it also increases the extrusion of phosphate. So your phosphate levels will go down. So hypomagnesemia can suppress your normal PTH response to calcium. So it's always important to replace your magnesium. So the effect of your parathyroid hormone, two functions. It increases your serum calcium and it decreases your serum phosphate. So if we look at hyperparathyroidism, it can be divided into three classes. First of all is your primary hyperparathyroidism, and that's usually your adenomas and hyperplasia. It's monoclonal in nature. So your secondary parathyroid hyperparathyroidism, that's your physiological compensation and hypertrophy of all parathyroid hormones, and it's usually due to hypocalcemia. We usually see it in chronic kidney diseases and vitamin D deficiencies. It will raise your PTH level, and you will have normal to low calcium levels. And then your tertiary hyperparathyroidism, that's the autonomous parathyroid hyperplasia, and that usually comes after long-standing secondary hyperparathyroidism. We usually see it in renal failure, and both your calcium and your phosphates levels will be raised. So the first step in diagnosing it is, first of all, to confirm hypercalcemia. So it's important to repeat your measurements, and you can do it by your total calcium corrected for albumin, and that gives us the true increase of your serum calcium concentration. It's also important to look at previous calcium levels if you have it available. So if a patient has long-standing asymptomatic hypercalcemia, it's usually suggestive of a primary hyperparathyroidism or your familial hypercalciuric hypercalcemia. And as we said, it's important to measure it in a fasting state and do not use antonicane. So if we look at your degree of hypercalcemia, usually primary hyperparathyroidism is usually associated with borderline or mild hypercalcemia, and that's usually when the levels are below 2.75. Values of 3.25 is more associated with malignancies. So it can be divided into three classes of severity: your mild, moderate, and severe. And if you use your ionized calcium levels, the levels are lower. And it's important to remember that it's your ionized calcium levels that's actually the physiological active ones. So if we look at your albumin calcium correction, so this, your hypercalcemia is often due to the elevation of your physiological calcium levels. So as we already said, 44 to 45% is bound to albumin. Your total calcium concentration is usually in correlation with your albumin levels. So patients who are chronically ill or malnutrition, like patients who have a low albumin level, you can underestimate your calcium levels. In patients who have severe dehydration, you can actually have a pseudo hypercalcemia. And then also in patients with multiple myeloma, they've got a hypergammaglobulinemia, and that's usually they've got elevated levels of globulins, and these patients can actually have an abnormal calcium because the calcium is bound to the globulin instead of the albumin. So you do get formulas that can correct it, but it's usually not accepted universally. So if we look at the clinical manifestations of hypercalcemia, it can affect your kidney, and you can have features of polyuria, polydipsia, kidney stones, They can have nephrogenic diabetes insipidus. They can have decreased renal function. The second one is gastrointestinal, where patients can have nausea, vomiting, pancreatitis, peptic ulcer disease. It can also affect the musculoskeletal function, where you can have muscle weakness, bone pain, osteopenia, and osteoporosis, neurological complications, decreased concentration, confusion, fatigue, and then also your cardiovascular symptoms. That's usually shortening of your QT interval, bradycardia, and hypertension. So just to summarize it, this is the picture that we all remember of symptoms. It gives you painful bones, stones, groans, and overtones. And this is just an easy mnemonic to remember. And if we see this picture, this is a lot of our patients that we get these vague symptoms that you actually really can't put your finger on it. It's important to remember hypercalcemia. So how do we determine the etiology of what is causing the hypercalcemia? So as we said, the important two causes are parathyroid mediated causes, and then you can also divide it in your non-parathyroid mediated causes. So the parathyroid mediated is, as we said, that's your things like your primary hyperparathyroidism, your tertiary hyperparathyroidism, and then there's also a group which we don't see a lot, your inherited variants. If we look at the non-parathyroid mediated causes, it's hypercalcemia of malignancy, also your vitamin D intoxication, and then also your chronic glomerular disorders that is characterized by the formation of granulomas. Another important cause to remember is always medications, and the medications that we use is actually the thiazide diuretics, and sometimes theophylline, vitamin D. Then there's also this other group of other causes, and those are the things like hyperthyroidism, acromegaly, pheochromocytoma, adrenal insufficiency, immobilization, diet, and then also your milk alkali syndrome. So an easy mnemonic to remember is chimpanzees that I found on the internet. Which is actually quite nice. But once again, as we said, 90% of cases is hyperparathyroidism and neoplasms. So what are the clinical clues in determining what is the cause for the hypercalcemia? And it can be obvious by finding out the patient's history and also by examination. As we said, so patients with primary hyperparathyroidism, they are usually asymptomatic. They can have a chronic hypercalcemia, usually postmenopausal women. You will find a normal examination and family history. While patients with hypercalcemia of malignancies, they've got a higher concentration of calcium. The calcium increases a lot more, and they are usually more symptomatic. And then patients usually typically have advanced disease and have a poor prognosis. So just to quickly talk about hypercalcemia in malignancies, and there's usually three ways that hypercalcemia can present in malignancy. First of all, is by tumor secretion of parathyroid hormone-related peptide. The second mechanism is due to osteolytic metastases, and you can have the release of local cytokines, including your osteoclast activating factors. And then usually the third one is also you can have tumor production of 1,25-dihydroxyvitamin D. So the ectopic secretion of PTH hormone can also cause it, but it is quite rare. So if we just look at the types of malignancies that can cause it, as we said, you can actually have the secretion of PTH-related hormone or peptide. That's your squamous cell carcinomas, renal cell, bladder, breast, lung, ovarian, prostate. So usually also non-Hodgkin's lymphoma, CML, leukemia, and lymphoma. The ones that give you osteolytic metastases is breast carcinoma, multiple myeloma, lymphoma, and leukemia. The ones that produce 1,25-dihydroxyvitamin D, those are your lymphomas, and also ovarian dysgerminomas. And the ones that's rare, that gives you ectopic PTH secretion, is your ovarian cancers, lung carcinomas, thyroid, rhabdomyosarcomas, and pancreatic sarcomas. So if we go back to putting this all together, is the first question is, does your patient have hypercalcemia? And it will be either yes or no. So, and if the level is more than 3.5. So if it is more than 3.5, we would treat it immediately. If the etiology of the hypercalcemia is unknown, we will measure then the PTH with a contaminant calcium level with albumin. And if the answer is no, we will first look at medications. If the patient is taking calcium or vitamin D, we would then repeat the calcium level and see if the calcium level is confirmed or not. The next step would be to test for your PTH level. So the PTH level can be either elevated, it can be normal or mildly elevated, or it can be normal. So how do we differentiate between the etiology based on your parathyroid hormone? So the first thing is, if it is PTH mediated, it's usually primary and tertiary hyperparathyroidism. If it's non-PTH mediated, it's usually malignancies, vitamin D intoxication, or your granulomatous diseases. There is actually in patients with malignancy a higher incidence of your primary hyperparathyroidism. And it's actually, you can actually test for your intact PTH assay as well, together with your calcium level, not to miss these diagnoses. So, as we said, if the PTH level is increased, it's likely primary hyperparathyroidism. If it is mild to slightly elevated to a normal PTH, it is usually primary hyperparathyroidism or your familiar hypocalciuric hypercalcemia. And there it is important to measure urinary calcium. If it is low, then it will be your non-PTH mediated hypercalcemia. So the next step would then be to measure your vitamin D metabolites, as well as your PTH-related protein, to find out if it is what the cause is. So if we go back to your vitamin D metabolites, we usually find two. So if the 25-hydroxyvitamin D is elevated, and usually levels about 150 nanograms per millimole, it is indication of vitamin D intoxicity. If the 125-dihydroxyvitamin D is elevated, it's usually due to direct intake, granulomatous diseases or lymphoma, or the increased production of vitamin D. So the next step, as we said, is to measure your PTH related peptide. So PTH related peptide, we measure it, especially if we suspect humoral hypercalcemia of malignancy. So is there any evidence of a malignancy that can cause hypercalcemia? And usually if the levels are elevated, it usually confirms the diagnosis. If the PTH-related peptide is not elevated, we would then look at the 1,25-hydroxy vitamin D levels. If that is elevated, it's usually lymphoma, granulomatous diseases like TB and sarcoidosis. If it is not elevated, we will then look at its use vitamin D toxicity, or you will then look at other causes. And that is where we will then measure the SPEP, the UPEP, and your serum free light chains, especially thinking about things like multiple myeloma. As we just to remind us, the causes for hypercalcemia, this is where the other group comes in, the hyperthyroidism, acromegaly, pheochromocytoma. All right. So other tests that you can also do, that you can to consider, is if you have a low PTH and also a PTH-related peptide with a low vitamin D level, you would then think about bone resorption and things like milk alkali syndrome. And as we said, the other tests to consider to exclude the other causes would be SPEP, UPEP, TSH, and also your vitamin A. So if we look at your serum phosphate and urinary calcium, so hyperparathyroidism and humoral hypercalcemia of malignancies, you would have a low phosphate levels and also serum phosphate. If you have granulomatous diseases or vitamin D intoxication, you would have normal or elevated serum phosphate. If you've got familial hypocalcuric hypercalcemia, the phosphate levels can actually vary. The urinary calcium excretion might be normal, high to normal, or even elevated in hyperparathyroidism or in hypercalcemia of malignancies. And then if you have low calcium urine excretion, and it's usually less than 2.25 millimoles per liters, you would then think about your milk alkali syndrome and thiazide diuretics, and also your familial hypocalcemic calcium. So other useful tests to look at can actually be your serum chloride concentration. So if it is more than 103, that's usually associated with low levels of bicarb. It can be associated with your primary hyperparathyroidism. So if the serum concentration is lower than that, it's usually associated with metabolic alkalosis, and you would then think about milk alkali syndrome. Other useful tests to do also is bone radiographs, especially if you think about primary hyperparathyroidism, as it can give you osteitis, fibrosis. I'm not going to ponder too much about the treatment of hypercalcemia. The big aim is to lower the calcium and to find the underlying cause for it. And if we just look quickly at what the interventions would be for patients with hypocalcemia, it's important to see the intervention as well as the mode of action and the onset. So Isotonic saline restores your intravascular volume and it increases the urinary excretion, and it can take a couple of hours. Your biphosphonates will increase your bone absorption via your osteoclast activity, and it can take 24 to 72 hours. Loop diuretics increases the excretion of calcium, can also take a couple of hours. And then your steroids works on two mechanisms. It decreases your intestinal calcium reabsorption, and it decreases your 1,25-dihydroxy vitamin D production, especially in granulomatous diseases or lymphoma. And then denosumab inhibits your bone resorption via your rank ligands. So, and then dialysis removes your calcium. So, yeah, as we said, there's no mode of action that works immediately, but it will take anything 24 hours to a couple of hours to restore the calcium levels. So this is just something on ChatGPT that I found quite interesting. So, and this is hypercalcemia's whisper. Basically, just say bones grow weary, stones may form, calcium rises, a silent storm. Thirst unquenched, fatigue takes hold, a story in blood, too much told. Confusion hums, the heartbeat slow, a balance lost, the body knows. Treat the cause, restore the flow, hypercalcemia, let it go.
Wow.
If you have any questions.
Thank you, Cornel. You always create some excitement, but this was really nice. But also means, I think for me, the presentation have a little bit of your OCD on it, that you're actually not missing every small point about hypercalcemia. And that actually brought us a lot of become very easy ABCD. I would always call it ABCD of hypercalcemia for the registrars and medical students, because really summarize everything. So my question is, especially for the lab, like, because we have laboratory experts here, do we do apartheid-related peptide in South Africa? Because I have always been entrenched about that. When I was TB, I presented hypercalcemia, and I needed to know, do we actually do that here? How do we know that? Because it's something that's been on the literature for a long time, and it's almost 10, 20 years since I qualified 2004. And I don't think that we still do that. Why?
We're not doing it. Yeah.
What's the reason? Because sometimes you have hypercalcemia, you can't find the cause. So we don't do them. Is it because of the cost issue? We don't have the gadgets, or there's no will, financial will not pay the labs?
I'm sure it's all about the method and the cost.
Yeah, but I think that's for me is important. But also, just another quick question, Cornel, to you, especially about the roles of a phosphate in diagnosis of hypercalcemia.
The role of phosphate.
Yeah, in serum and in urine. Does that actually help you to distinguish which one from which?
Yes, it does. So, yeah, as we said in the presentation, so usually your hyperparathyroidisms, because phosphate, with hyperparathyroidism, you would decrease your phosphate. So your phosphate levels will be low.
On the serum?
On the serum.
In the urine?
And in high in the urine.
Yeah, and then in the urine outline, in the familial hyperuricemia, now your phosphate in urine will be low, but in serum will be slightly high, I think. Yes?
Potassium? I think it is low in hyperparathyroidism.
Potassium, I'm thinking about the link between the two. Potassium, ideally, I'm not so sure. It should be more phosphate, actually. I think maybe because I'm not so sure. Potassium.
I think there is.
In hyper, in how?
In hyper.
Would that be because of catabolism or would that be because of the?
I'm not sure. I read it because I have a patient and I've got a very interesting patient related to this topic. She's a patient that was referred to me in Bedbank. She was referred to me, she had a hypercalcemia. They went, I think they did a isotope scan and they did a parathyroidectomy. So she was then worked up for this hypercalcemia that was still persistent and found to have a multiple myeloma. So that's where I came in. I've started her on treatment. I gave her Zomabon, zoledronic acid, did nothing to the calcium levels. Then I motivated for Prolia, which we were just starting to use in hematology, but oncologists were using it. Still not making a difference in her asymptomatic hypercalcemia. Till today, and she's well down the line, the M protein is gone. She's got no light chains, still presenting with a hypercalcemia. So I did a PTH again, and it was raised, and only to find out she had a partial parathyroidectomy. So my question now is, okay, PTH is raised. She's got a partial parathyroidectomy. Will she survive if I do a total parathyroidectomy?
Ideally, yes, because ideally she should survive because remember there's 4 parathyroid glands, and in the past what the surgeon does, they implant it in the arm. Then you have it. And also, but also I think the mistake that we're doing is that people always do nuclear medicine to localize the adenoma. That's what they start as a first test, which is actually wrong. You should never have done that test because the moment that you could have parathyroid glands, the moment you find that there's a gland there, your brain stops working. You think that's the problem. Most of the time, sometimes it's not the problem. That's why you only do that test if you think that you have excluded all the causes, and also you're going to that become the obvious, and then you do resection. So is that actually one of the last tests? And
so this partial resection was done. So there's 2 more glands, or one was difficult to access or something. So I'm not entirely sure if that is now the reason for her persistent hypercalcemia, because I've treated the myeloma and she's on the second denosumab, and it's still persistent, and she's got a hypokalemia now.
But one of the things that I did see, and that was quite interesting, is, as I said, so even patients with malignancies, it's important to rule out primary hyperparathyroidism because they can have hyperparathyroidism even if they have a malignancy. Yeah. It's important, if you've diagnosed a malignancy, not just to say the hypercalcemia is because of the malignancy, you have to still go and look, you can still go and look for, especially if it doesn't get better. So
I mean, I'm assuming now for me, she's got hyperparathyroidism. That's the explanation.
Because myeloma should actually give you a low PTH because you should have a positive, negative feedback, and then PTH should be low. But now if the PTH is high, so it means it's a different drivers.
Yeah.
So it could be maybe metachronizing kind of problems that happen at the same time.
So that was my question. Should I remove the remaining parathyroids?
Well, you're not removing the remaining. That's a pathological parathyroid gland, so that deserve to come out because you're still having the 4 parathyroid, the two now you're having 2.5. Obviously, how come they actually took half of it? That's quite
and I
really
think
weird.
It might be the access they struggled at some point. So this is what I'm hearing from the patient's daughter. So I don't know if that's the cause, but what do I do with this lady?
How old is the lady?
She's in her 60s. She doesn't want a transplant. Okay, so that's for the myeloma.
And she also got, does she have renal issues?
Nope, no renal issues.
Very interesting.
She's a good, healthy, fit lady. I mean, not fit. She's a bit frail, but this is the situation I'm faced with.
I think she needs to have a very good physician who could start from day 0 and restart assessing her again. Someone who's not mentally biased to have a look and then reapproach. I always say that you step backward and reapproach again. Where is the problem? Look at all the parameters. I mean, now we have an expert here, and you need to look in more detail to say where are we exactly, and make the important kind of saying, is it PTH related or none? And I think in this kind of patient, these are patients that actually we should be sending blood to Mayo clinics to test for parathyroid related peptide and see whether that's malignancy related or not. But one, I know that most of the PTH related peptide, they tend to be more primary lung tumors, like small cell carcinomas. they tend to have this as a part of paraneoplastic and also squamous carcinomas, also the culprit that produce those kind of stuff and also some mediastinal tumors.
I've done a PET CT and I don't think those were anything that's striking to me, but I'll have a look again at the scans.
What is the calcium levels?
It varies from 2.7 to 3.2,
It's very high.
and that's corrected.
And the ionizing obvious is very high.
Yeah, so that's where I am with her right now. And she doesn't have money to come here.
Yeah.
You know,
It's
so
a private patient.
it's from Vet Bank. She's got medical aid, but they don't have the funding.
Look, I think this is why we have this platform. I mean, the doctors there actually ideally, because the problem that most physicians, they are in private practice on their own. There's no ongoing learning. And that's why it's the biggest, I mean, look, it takes time to prepare these presentations and to be sitting here at 7:00. It's not a waste of time because it's kind of, I think we need to provide solution for our patients. And that's why I think it's very important that the physician in Wheatbank ideally should be able to do
I've
it.
spoken to the physician in Vet Bank and didn't get any job.
Yeah, no, but expected because they're busy. Because everybody think that they're busy, but busy with what? Yes, with patient, but what about our roles as a clinician provide solution to a patient outcome? Now, if you cannot get solution to this patient outcome, why move to the next patient? Because at the end of the day, we need to address whoever we have because, I mean, they have nowhere to go. If you can't give solutions, it's actually unfair for the patient that travel from Wheatbank to here just to find another physician. It's expensive. We don't have all the backup money, you know, because ideally it should be addressed there. And I think, yeah, I don't know, maybe we need to just see which physician is that and then see, because there are quite a few of them there, not quite many. Others are getting a bit older a bit, but I think could have been nice to find somebody and then they liaise with us and see what tests they need to do. But I would probably send some sample to US, like
But the patient would have to pay for it.
yeah, it's normally actually not super expensive. It's actually cheaper than for her to be traveling to Victoria. So most of the times, I mean, we know Oxford before it's just for cost 3,000-4,000 rand, but some that can be arranged with the patient, especially. Yeah, but I think something that's why I think in future I wish we could do some of those tests around because we do have the patients. But let's see. But yeah, but very interesting. Leanne, any perspective? You've been quiet for this morning.
I think it's something we see quite often. I mean, we're dealing with it on a daily basis, so it's a really nice topic.
Vitamin A related to toxicity to see when you mentioned it as cause.
Yeah, I think it is with the milk alkali syndrome.
Oh, okay.
So
I mean, just as an aside in your practice as clinicians, I mean, patients now take like all kinds of supplements, like sweets. Do you see these kind of toxicities, not necessarily calcium, but with genuinely because of all of this?
it can. So, but usually the patients that we see with slightly elevated calciums, and it doesn't go up to over 3, and patients would come to you, they refer patients to you with a calcium of, for instance, 2.75, which isn't, it's just mildly elevated. You would then look for a cause. Now, then you would tell patients to stop vitamin D supplementation, but it doesn't go up that high. And it's also important to remember there's a reference range. So if it is like 2.6, it's not really hypercalcemia. And especially if the patient doesn't have symptoms, you would go and look for a cause, monitor it, stop calcium, and then vitamin D. But I haven't seen any intoxication of high levels
The
of
levels you talked about was
150 of vitamin D.
Vitamin D. I mean, we often see or argue up to like 70, 80,
Yes.
which is high.
But it's not intoxication.
usually due to supplementation, which
Yes.
is correct.
Yes, I think we've seen that a lot.
And if you stop it, it normally comes down. So
But in COPD patient, we normally give them vitamin D because we've got a lot of anti-inflammatory effect and also the fact that if you look at the mechanism of vitamin D, because we work on the nuclear, it's kind of got a lot of issues to do, a lot of good thing with the nuclear kappa B and all those switch off certain kind of inflammatory genes, and the outcome is really quite good. But I think there was a study that was done about 2, 3, 5 years ago that they reviewed the effect of the supplements, especially vitamins, on elderly people, and they actually found that's actually increased mortality. And the one which probably might not have increased mortality is more vitamin D and zinc, but majority of those supplements, they're never good for the patient. But obviously, there is that they are always driven out there. Remember, it's a big market of the and highly profitable that people are driving supplements. Obviously, for profit need that vitamins help and everything. But the truth that the way we are created, whether God created us or not, but we are created with kind of to be able to extract those nutrients through our GIT system. And obviously, most of and that's why sometimes the vitamin D with the sun, and some of the food from the vegetables, meat, and everything. So they kind of big role that you could actually.
It's very essential. In a lot of studies that have been done, they improve the mortality of our malignant patients with multiple malignancies. So,
Yeah, because of the inflammatory. Yeah, I think next discussion, we should discuss a bit of role of vitamin D and steroids in general setting, because I think they're kind of synergetic effect, and also see how it works, because one of them are really steroids kind of work on the steroid they're all acting uniquely. I think if I remember, it's tend to be corrected, but I think maybe it would be nice next we should actually get into dive and discuss vitamin D and yeah, I think maybe that would be nice.
Good. One thing that I've seen in practice, because you read it in books and as a student know that if you've got high calcium levels with a high PTH, it's primary hyperparathyroidism, and you go and look for primary and you do scan, and very rarely it comes back positive, so you would think, and now the problem is, okay, now you've got a negative scan, what now? So, because scans are quite expensive as well, so you don't always, it's nice if you can localize a lesion and say, yes, this is primary hyperparathyroidism, but it doesn't always work that way. Sometimes you have to remeasure the levels, see if the patient does have symptoms or not, before you go and explore things like scans and stuff like that.
But also knowing that PTH is actually a marker for chronic renal failure. So we do that also as a marker. Elevation does not equal to primary. I think we also emphasize that before you go and look at the nuclear medicine scan to localize parathyroid gland, you need to do all the investigation and find out there's no other possible cause that can explain the underlying hypercalcemia, but also maybe you look at the diet of the patient and make sure that the supplements and make sure that he's actually not using them, because most patients take supplement and they don't know actually what is it, and it's very important just to always ask for that, and especially elderly people with dementia, because they've got dementia, they've got memory issue, and it's a normal human process, isn't it? Anybody online? Is there anyone online?
Yeah, great presentation from my side. No questions. Good morning, all.
Thanks, Dr. Cody. We'll try to put you on the CPD point. Did you get your CPD last week?
And no, I didn't.
It's submitted once a month.
Oh, okay, thanks.
Okay, yeah. Thank you for joining us. I think.